So unfortunately, there's not one easy way to peg malnutrition in a patient. There's a lot of different things to look at. So that's where getting a dietitian involved can really help to kind of piece all the little pieces together to get a good sense for their nutrition status. So the first thing that I look at is just what are they eating. So it requires sitting down with the patient, talking about their appetite, how many times do you eat a day, what types of things are you eating, how has it changed recently. Nutrition-focused physical exams, which is a great way to get more hands-on with the patient, get that extra level of assessment in. So we're looking at different areas of the body, like the orbital area, the temporal area, triceps, and there's a few others to see any signs of fat or muscle wasting. So sometimes you can pick up things there if there's not necessarily weight loss, so it's just another tool. The first one is education. So that's a big piece for these patients because the shortcut diet is not intuitive. It's not something that most people have heard of or thought about. And it can be complex depending on the patient's needs, and there's a lot of pieces to it. You have chewing well, small frequent meals, avoiding sugar, drinking Pedialyte or an oral rehydration solution if they need it. So just kind of educating them on each of those pieces, re-educating on those pieces. It's impossible for them to remember it all the first shot. I'd say that's a big piece of it. And then secondly is the actual intervention. So getting patients set up with snacks in between the meals so that we can do that small frequent meal pattern, ordering them Pedialyte. Some of these patients need parenteral nutrition if they're unable to absorb enough, so kind of working with that, and or tube feedings. A lot of times we'll do tube feedings if we can. And it's so important that we're all giving the patient the same message. Not only does it reduce confusion, but it helps the patient kind of buy into the shortcut diet. Some of it seems crazy when we tell them you can't drink any water.
So like everybody in America is like, drink more water.
Right, exactly. So if they're hearing it from the nurse, from the doctor, from me, their family members, I try to educate them too, so they're getting the same message all around. I think that's
almost done. How does the surgery team help you to do what you do? Like a lot of times we have discussions about like where the fistula is on the bowel. Like,
yes.
Can you explain that a little bit?
Yeah, that is a huge help to me, knowing exactly where that fistula is located, because that's very much going to affect my nutrition plan for the patient. If it's fairly distal, then I know we can maybe be a little more relaxed. Where if it's in the middle of the small intestine or proximal, that's definitely going to be a different nutrition plan. Might even need TPN at that point. So that's helpful. Also knowing just the overall plan for the patient, like are they not a surgical candidate? So this is what we have to work with, or is their correction going to be in a month or 6 months, longer than that? That kind of just helps me get a good plan together and educate the patient and motivate them based on that.
That's awesome. Okay.
So I love what I do and the team I work with. It's a great group. So.